minutes each in the first round to have switch between these two labs, and then the last 7 minutes back to back for the final concluding remarks. All of them would be in total of 55 minutes. With these few words, may I invite the chairpersons, Professor Shantanu Guha, Drs. M.S. Hiremat, P.K. Ashokan, Suresh V. Sagrad, and members of the expert panel, Dr. Samir Dani, B.C. Srinivas, Chandrasekhar and Makhle, Rabin Chakrabarti, and Nishit Choksi from the United States of America. Gentlemen, the stage is all yours. I think we'll establish the contact. If we can have Dr. Hiremat and the other members and panel of chair to kindly establish contact firstly with Professor N.N. Khanna and 20 minutes down the line with Professor Manjunath. Can we have... but in the meanwhile, both the labs will be going live. The audio feed would come every 20 minutes back to back. I think Professor Khanna is ready. If Dr. Hiremat can establish contact with Professor Khanna, we'll get going.
Yeah, Dr. Yes. Khanna, we are with you. We are ready for you.
Okay, okay. They'll just take a minute, Dr. Hiremat, because you're just going to get through.
That's fine.
First, okay. The first 20 minutes is with Professor Manjunath. So I think you can establish contact with them.
Dr. Manjunath, can you hear us? So we are going to be with Manjunath?
Yeah, the first 20 minutes with Professor Manjunath and the next 20 minutes with Professor.
Oh, 60 is...
जरा मुझे first वाला दिखाओ, ये वाला है ना?
Yeah, we are exactly there.
Where?
There.
Here?
No, no, here, here.
Good angio here. Give me a while.
We can go with Dr. Khanna.
हम एक और करेंगे, then we don't move the table after that. No, one will take us in.
Dr. Khanna, can you hear us by any chance?
I think we are first going live to Jayadeva. We'll just have it.
Okay, Dr. Manjunath, can you hear us?
ऊपर दिखाओ.
Yeah, very well. Good afternoon, Dr. Hiremat. Yeah.
Yeah, Dr. Manjunath,
Hiremat
Hiremat
we are
here.
hearing you.
Yeah, I think so. Let's see कितना होगा.
With me, we have Dr. Makhle, Dr. Ashokan, Dr. Nishit Choksi, and Samir Dani.
And I think after this,
we are ready for you. Your story.
I asked Dr. Manjunath to finish 2 cases.
Yeah, good afternoon to all of you.
Have half an hour, 20 minutes.
Be a little louder.
I think what we'll do.
See, little different from, little different from the morning. We are moving from coronary to valve here. This is a 37-year-old lady of rheumatic mitral stenosis. I can see here she is in atrial fibrillation and left atrial appendage clot type 1A as based on our classification. She was anticoagulated for 3 months. So she is in function class 3, atrial fibrillation, and heart rate on the table is about 120. Blood pressure is 120 by 80. And we'll show the other pictures. This is next atrial fibrillation. This is typical X-ray of rheumatic mitral stenosis, pulmonary hypertension. And you can see here the parasternal axis shows dooming of the mitral valve and bit of calcium on the posterior mitral leaflet. Then in the left lower panel, you can see the short axis of the mitral valve that orifice is less than 1. And there is TR. And there is pulmonary artery hypertension is around 70. Pulmonary artery systolic pressure is 70. If you look at the short axis of the mitral valve, the anterolateral commissure is free from calcium, while the posteromedial there is some amount of calcium. This is very, very important because if both the commissures are calcified, then there is always a risk of leaflet tear. So at least if one of the commissure is free from calcium, you can still have a balloon mitral valvuloplasty. This is a transesophageal echo for you. You can see a clot confined to the LA appendage, protruding a little bit into the body. And of course, there is spontaneous echo contrast. So since the clot is confined to the appendage body and anticoagulated for about 3 months, we are going ahead with the balloon mitral valvuloplasty because our hardwares will not be into the appendage at all, and the clot is also organized. Yeah, this is the story of this patient, Dr. Iramat.
Yeah, I'm surprised they kept half hour for you, Dr. Manjunath. I mean, I'm sure you'll finish in a few minutes. That's
No,
what
no,
I mean.
no. Okay. So only thing, we have to use a 3-2 wire for threading the Mullen sheath because the Mullen sheath doesn't go over 3-5 because most of our labs do have only 3-5. So if you, unless you have a 3-2 wire, Mullen sheath doesn't slide. So you can always see that this sparks, I mean, you can maneuver so that it is in the left innominate vein so that when you are coming down, it gets an angle onto the atrial septum. This patient actually was on anticoagulation, stopped 5 days back. INR yesterday was 1.3.
Was she anticoagulated for a length of time earlier or no?
Yeah, she was anticoagulated for about 3 months. The whole objective of anticoagulation is let the clot become more adherent and more these things. So I'm, yeah, LV40. So I'm just one space below in AP view, then I'm going to LV40.
Low puncture.
So LV40 we have to pick up a point between pigtail anteriorly, vertebral column posteriorly. So you can see I'm just injecting, we are in the left atrium now. So now I will just advance the Mullen sheath, keep over the broken barrel needle. Because you should not advance with the needle projecting beyond the Mullen sheath because there is always a chance of perforation. So can you show the pressure? We are into the left atrium actually, now we are in LA. So let me take a simultaneous LV as well as LA pressure. Can we show that? So there is a big diastolic gradient, okay? LA pressure is 53/24, mean of 38.
Yeah, we can see that very well.
So with, yeah, so we'll go with the spring guide wire now. Yeah. I always keep pigtail in descending aorta. Any flushes and all, you can always do it. See now, to know whether you have gone to the softest portion of the septum, just the Mullen sheath itself you can advance and see. Yes, Mullen sheath is going smoothly. So probably it has gone through the softest portion of the AS. Many people say I've always punctured at fossa vallis, which I don't believe. Many times you are across fossa vallis, sometimes it's above fossa vallis, sometimes it's below fossa vallis.
You are a very honest interventionist, Manjunath.
So this is 30, I mean our height is 165. So we are going to, because as per the formula we have to take 25 balloon, but I will downsize by 2. See, many a time, rather than doing multiple runs of the septal dilator, you can just dilate, keep it for 30 seconds, it stretches the septum nicely. Of because septal puncture is not just for balloon mitral valvuloplasty, we have other procedures, LA appendage closure, left heart catheterization, mitral clip device, so many things.
So what are going to be the special steps?
Another important thing is you have to always keep an eye on the
Special steps to avoid the clot.
you have to keep an eye always on the left. Yeah, I think since it is an appendage clot, I am just doing routinely. Otherwise, if the clot were to be in the roof of the thing, we would have done over the wire technique. That is where we introduce the spring guide wire instead of LA into the LV itself. See here, when once 2/3 of the stretched balloon crosses this thing, you release this balloon stretching tube so that it doesn't get into that zone. Yeah. Always, I never flush into the left atrium. Always we keep aspirating because
what about the heparin? Have you already given the heparin?
so we have to come and look for this.
Dr. Manjunath?
Heparin 3000 units we have given. Yeah, 3000 units given. Before septal puncture only I had given. Because sometimes you can give after septal puncture, sometimes. So you can always watch for this bobbing movement. That means you are on top of the mitral valve. So one thing, you always make sure that the balloon reaches the apex, otherwise it can get stuck in the subalveolar apparatus. 50%? Yeah. Oh, sir, okay. 1 second. Yeah. $50? Yeah, come on. Very okay.
Full breakfast.
So we'll just check with the gradient as well as the mitral valve area.
There is one systemic.
So because you're slightly undersized, you could go full on the inflation, right?
Yeah. Elena?
Yeah, LA.
Huh?
LA.
Okay. We'll superimpose. I think always you should inflate, Dr. Iramet, at a high pressure zone. So, see here our required balloon diameter was 24. So I inflated I have taken a 26 balloon. So if you inflate at 24 in a 26 balloon, you generate a great pressure. Suppose if you take 28 balloon and inflate at 24, then you will not generate that great pressure. So we have to inflate balloon at a high pressure zone. So if your required diameter is 24, you take 26 balloon, or if your required diameter is 22, you take 24 balloon.
So is there something like soft dilatation, like if there is an associated
Otherwise,
mitral regurg, people underdo the dilatation? Is that acceptable or no?
no, if there is a calcium or if there is MR, you can downsize the balloon by 2 millimeters. So it's fine.
LA pressure is still high, 25.
I think with a heart rate of 144, a gradient of around almost diastole it is touching,
ತೋರಿಸ್ಬಿಡಿ ಇದು
just to, you can show the,
pressure.
yeah. You'll have an echo?
So
Yeah.
you can show that.
No, no, it's coming, coming. Yeah, it's a wide jet actually. In fact, LA pressure has, mean has dropped from 35 to 17. So you can see here a wide jet. Because of atrial fibrillation, fast heart rate, so you can go on the short axis and show. Yeah, I think you can zoom that.
ಬೇಡ ಬಿಡಿ ಪ್ರೆಷರ್ ಬೇಡ
Yeah, freeze, 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 freeze.
ಪ್ರೆಷರ್ ಬದಲಿಗೆ ಎಕೋ ಕೊಡಿ ಎಕೋ ಕೊಡಿ
Echo, echo.
Instead
Show
of
the echo,
pressure, show
please.
the echo. Yeah. Running.
Yeah, you can show, you can see here both anterolateral as well as posterior medial commissure is well split.
Yeah, we can see that.
And
on
there
the
is no
echo.
MR. Hello?
Yeah,
I
we
think
can see
lost
it well
the
on the echo.
Contact. It's fine, it is. Hello?
Yeah, we can see it very well. Well, how much is the area now?
He's asking why they are giving Manjunath 30 minutes. For you, 5 minutes is enough. ಅಲ್ಲ
So we-
ಇದಾಯ್ತಲ್ಲ gradient test.
So Dr. Manjunath, you're 5 minutes ahead of time. Nishit, any comments from you? Interesting that you are here.
I don't do much of
Hello?
valvuloplasty.
What is happening with the audio?
Done
I mean,
couple
audio
Dr. Ben's
visual.
mitral valve replacement,
ಏನು ಬರ್ತಾ ಇಲ್ವಲ್ಲ?
and they worked out very well. We use the
48.
sapien
Hello?
aortic valve
Hello?
in mitral position.
Yeah,
Hello?
Manjunath, we can hear you.
ಸೌಂಡ್ ಬರ್ತದೆ.
Short
Back in
axis.
US, we don't get
ಏನು ಹೋಗ್ತಾ ಇಲ್ಲ ಅನ್ಸುತ್ತೆ.
too much of these mitral valves, but every now and then there is
Zoom ಮಾಡಿ.
prosthetic mitral valve stenosis.
ಯಾಕೆಂದ್ರೆ heart rate fast ಇದೆಯಲ್ಲ.
So where do you think the septal puncture technique would be useful for you in
You
US?
take that.
Pardon?
Septal puncture techniques,
Both are split.
where it will be useful for you in United
This one it should
States?
be there. Hello?
For this mitral
And what
valves,
is happening?
for atrial appendage occluders, they're very important.
All right, Mr. Padmanabh, can we switch to Dr. Khanna's?
Yeah. ಅಲ್ಲ ಆಗೋಯ್ತು ನಮ್ದು.
Mitral clips are
ಆಗೋಯ್ತು,
very,
ಬಿಡಿ.
mitral
Hello?
valves
ಬೇಕಾಗಿಲ್ಲ, both
will be very
commissions
important to
split.
do.
Yeah, yeah. So you can
Posterior,
see here,
inferior,
uh,
puncture.
actually you can see here the short axis of the mitral valve. Both the commissures are split. See,
ನೀವು ಮಾತಾಡೋದು ಕೇಳಿಸ್ತಾ ಇದೆಯಂತೆ. ಯು ಜಸ್ಟ್ ಕೀಪ್ ಟಾಕಿಂಗ್ ಅನ್ಸುತ್ತೆ.
yeah, yeah. So both the commissures are split and I think end diastolic, yeah. I think I don't want to dilate anything further here because we have achieved a good area is around 1.8 and LA pressure has dropped and end diastolic gradient is hardly 2 to 3. See, when we are removing the balloon from the left atrium to right atrium, normally you have to put back the spring guide wire and this thing. If it comes smoothly, it is fine. Here it is coming smoothly, that's okay. And let me check the RV pressure rather than going for an exchange with the NH catheter, endole catheter. Let me check the RV pressure with the mitral balloon itself. So, because otherwise it takes lot of other exchange and all. Dr. Iramet,
Yeah, we are
Hello?
watching that, yes. So that's
you are with
RV.
us?
Yeah, this is
Yeah.
RV, right?
Baseline
See, RV pressure before the procedure was 75 systolic, and now it's around 59, 55, 59.
Can you show the hemodynamic? Yeah.
So this is one. I think with the same mitral balloon, you can check the RV pressure, which indirectly always gives pulmonary artery systolic pressure. Otherwise, you have to exchange for this again spring guide wire. Then you have to introduce, I mean, endol or those catheters. So this will shorten the fluoroscopic time. So definitely, PA pressure has dropped from 75 to 50. 50 now. Can sh-
ಬರ್ತದೆ ಎಲ್ಲಿದೆ ಬೇಸ್ಲೈನ್ ಟಚ್ ಆಗ್ತಿಲ್ಲ
Yeah. See, when we are stretching the balloon, one point here, you have to keep the spring guide wire loop well in the, at least 2 loops should be there in the right atrium, beyond this balloon tip. Yeah, go the, have the loop, yeah, still. See, otherwise what happens, if only tip of the wire is projecting, then you try to stretch the balloon, that wire can get cut. So best is have 2 loops beyond the balloon, then you can lock and stretch the balloon and remove it. So I think this is for you. Any questions from the panel or?
ಆಡಿಯನ್ಸ್
No, that was
Hello?
Dr. Manjunath, that was
Again
excellent case
disconnected.
demonstration. Actually, BMVs by and
Hello?
large nowadays are
ಫ್ಲೂರೋ ಮಾಡ್ತಾರೆ
sort of not done by many people. So I think this was an excellent case study. Step by step, particularly with the electrode.
Anyway, procedure.
Okay, Dr. Manjunath, that was great. Thank you indeed. I told Dr. Khanna that keeping half hour for you
pressure
is
was
going
shown,
to
they
be
were
too
there
much,
with
and
us.
that's quite true. So we move on to the other lab. Thank you, Dr. Manjunath, again.
ಆಯ್ತಮ್ಮ
Nodi, see how heart rate drops when once.
Shall we move to Dr. Khanna?
Very good result.
Get me 7. Yeah. Move. $760. Fast, fast, fast.
Dr. Khanna, we are with you.
Okay.
Dr. Manjunath has already finished, so you gave him too much time.
Oh, yeah. With me is Dr. Sarath, and we have a case of triple vessel coronary artery disease, post bypass hypertensive diabetic with borderline nephropathy. And this patient, only surviving graft is hemoglobin, and he has presented with very severe claudication. And he is admitted here, so we have done an angio, and I'm going to show you run through the angio.
We're not getting picture here.
You're not getting the picture?
No. It's some technical problem.
Can you see it now?
No, nothing. It's a blank, black.
Yes, so why then you correct this? Hello?
Mr. Padmanabh, we have no images.
Can you see us live or you can't even see us live?
No, we got the images, yeah.
Okay. So this is the first shoot which we have done through a pigtail, and what you see is there's a mild renal artery stenosis, a very severely calcified and ulcerated plug in the abdominal aorta, which is infrarenal, and then there is a tight aortoiliac disease at the bifurcation, and then both sides, the external iliacs and common iliacs, are diffusely diseased. So this is what we have right now, and we need to treat this. The pressure gradient across the stenosis is about 60 millimeter mercury. So I would ask the panel, what would be their strategy to treat this patient?
So, problem here is we are getting images only intermittently, but
Just say the image is not getting from the cath lab, no? Ask Mr. Vikas to come here.
we don't know. The problem is that the transmission at your end
Can
or
we have the
receiving at our
images? Dr.
I'm sure it must be at your end because
Can't see the picture.
Any comments
Can
on
you
that,
see-
Nishit, or maybe Samir?
वहाँ इमेज क्यों नहीं आ रहे? इसकी नहीं आ रही लैब की फ्लोरो. Are you seeing the image now?
So there is ulcerated plaque before the bifurcation. It's like a dissection there or something.
I can't hear you. I can't hear. मुझे सुनाई नहीं पड़ रहा उनका.
Is there
वहाँ
an
से-
ulcerated plaque in the aorta? Is that that's a
Yeah,
question?
that's so that's a big ulcerated plaque. We have done a CT also on this patient, but I can't show you the image because it doesn't loop here and it's not integrated. But there is a calcified plaque in the infrarenal abdominal aorta and which is ulcerated and almost it's like a really bad shaggy plaque there.
And Dr. Khanna, the distal runoff is good?
The distal runoff, we couldn't feel the pulse on the left side, and on the right side, the pulse was very poor, and we haven't seen the runoff in the lower limb, but as per the Doppler, there is no stenosis in the femorals, popliteal, or below knee vessels.
As I see, there is a stenosis at the origin of both internal iliacs. So,
True.
Is a kind of a consideration when you're going to stent the iliacs apart from aorta, or no consideration?
I probably don't think those are important because there is an extensive collateralization in the pelvic area. And I don't think we are going to sort of, once we stent across these iliacs, we are not going to occlude either of them. And the patient doesn't give any history of pelvic ischemia or, a rectal problem.
All right, I think the decision, any thoughts from the panel, Samir? How would you do it?
We can either put just an extension limb in the distal aorta, not going into the iliacs, or you can put a bifurcating stent graft from the renal down into the iliacs, cover the proximal right common iliac, and the left side of the common iliac looks okay, but that's what that would be one. There will be two options there, two choices there. What kind of graft are you planning to use?
I actually am not planning to put any graft. What I want is just to put in 2 stents in the external iliacs up to just before the bifurcation of aorta, and then extend this up and extend the carina all the way up to below infrarenal region above that ulcerated plaque. So I want to not meddle with this. And I don't think, once we do this, there will be a risk of, aortic trash or a rupture. That is what my philosophy is, but I'm open to suggestions.
But I would have imagined that if you had put a covered stents in the iliac, the restenosis possibility is clearly less than a conventional stent.
If you closely look at it, if you put a covered stent, you mean covered stents recreating the carina or
No.
putting in a stent graft?
I would put a separate stent in the aorta. I would probably use a balloon expandable stent in the lower portion of the aorta, and then put 2 covered stents from either iliac coming into the aorta.
True.
And that is why I was worried about the narrowing of the internal iliacs. If you're putting a covered stent, which is going to go across the mouth of internal iliacs.
Actually, that was my strategy also, but that would have worked well, if we had the stent graft, if we had a stent graft here, but we don't have an atrium in this lab, and the only stent graft we have is a wall graft, and this wall graft doesn't fit into the size, so I have a real apprehension if I stent with a wall graft in the aorta, it may actually come into one of the iliacs.
The only concern is when you see such an ulcerated plaque in the aorta, if you put a non-covered stent, there's a fairly good chance of distal embolization from the cholesterol particles there. And therefore, when somebody has that much of an ulcerated plaque in the aorta, a covered stent, if you have, would be preferable. If you don't have,
yeah, we don't have it right now. If I had, I would have definitely used it. I would have used 3 atriums, 1 in the aorta, abdominal aorta, and 2 into the iliacs, and then extended that with a non-covered stent. That would have been my strategy. because that's the area where the maximum calcium and the plaque is. But
would
short of
not-
that, we just want to do it simple like this.
I wouldn't worry about the internal iliacs because if you're putting a non-covered stent there, even if you curve the internal iliac, you can always go through the strut and dilate the internal iliacs. As long as one of them is open, you'll be all right. On the left side, there is some cuff that you have in the internal iliac, so you should be all right there. On the right side is ostial, so it may close, it may not close, but as long as you got one good internal iliac, you're okay. So I think the only disadvantage of putting in 2 stents and recreating the carina is in the future, if you want to come down into the infrainguinal vessels, it might become difficult. Unless you go through the
It could
stent.
be difficult, but if you want to come from radial or brachial, it shouldn't be that difficult. Because we are what
You mentioned a gradient of 60 millimeter.
60 millimeter
That was
acro-
between which 2 points?
between the suprarenal aorta and the femoral. So we don't know between, it's not like now we can do a segmental pressure analysis here. So what we get here is the 60 millimeter pressure gradient, and we have to work with the limited stock which we have for
Why
vascular.
not just put a covered stent in aorta and get away with it? Because what do you think is causing the symptoms in this gentleman?
I think it's the aortic bifurcation lesion and also the lesion in the external iliacs on the right side. Because we have seen that in CT, this is a angio which you are seeing here, but I have seen the CT. The tightest lesion is at the aortic bifurcation.
All right, so what is your plan, Dr.
Okay,
Khanna?
so with the limited hardware I had, my plan initially was to do a covered stent in the aorta and then have 2 non-covered stents or 2 atriums down to recreate the carina inside that. But since we do not have that, the other option which we found that we want to recreate the carina and start stenting, a double barrel stenting right from the infrarenal aorta down above the plaque down to the external iliacs on both sides.
Sounds good,
So,
yes.
so can I go next?
Yeah, thanks.
Okay, so this is, we try to wire it, just I wanted to show, if you want to wire, you should always take a pigtail and rotate it. Otherwise, with this sort of an ulcerated plaque, you can easily go subintimal and create real problems. So here, what we have done with the help of a pigtail, we are going up with the wire. Next. And again, this wire gets stuck here. Next. So again, with the help of a catheter, we go up and we pass in 2 magic torque wires. Next. Next. So then we take a 5 millimeter balloon on either side. This is also good for measuring, and we want to just create a space where we can pass in our stents. And this is a dilatation with 5 millimeter balloons on both sides. This is right from the aortic bifurcation. Next.
What diameter is that?
These are 5 millimeter diameter either side and 60 millimeter in length. And then we dilate the external iliacs. Next. Go next. And then the external iliac on the right side. Next. Go next. And then we take both the balloons up. Next. And then dilate simultaneously in the abdominal aorta. And these are 2 5 millimeter balloons. And here we also sort of size it, and we know that what size of stents we are going to use. Go next. Next.
Dr. Khanna, since the patient has some renal compromise, are there ways to save on contrast by...
Yes. What we are doing here is, one that we are using a 50-50 contrast. The other thing is we are doing a mapping or marking on the fluoroscopic screen. And we are using the bony landmark. And with the help of that, we are sure that we are going to be saving contrast. But at the same time, we don't want to save on a contrast and miss a small perforation or dissection in the aorta. So we do have to, our plan is to minimize the contrast to about 50 ml. And I think we are nearly close to that.
So can't we do something like trace subtract where you have an image permanently fixed there? And
We
you
can actually, but this lab doesn't have that. And the other thing is we are working in one field. We are not able to cover the external iliacs and the abdominal aorta in one field. So we have to do it in two different frames.
Maybe the image intensifier size. Khanna, another question. Have you used
Go
carbon
next.
dioxide as a contrast medium?
Not here, but in my lab I use carbon dioxide in these sort of cases, and it's very good for diaphragmatic lesions, so it's pretty good, and you can easily do the procedure with no contrast or a very minimal contrast at the end of the procedure.
Particularly with the renal compromise, it is a good contrast.
Okay, so what we have done here is, just for the go minus, we have put 2 8 in, go minus.
Minus.
2 8 into, no, come back, minus. We have put 2 8 into 60 millimeter stents on either sides covering the external iliac lesions, and after that we want to put 2 10 into 10 millimeter epics to recreate the carina. So we have done this. Now the problem is, while going on the left side, the stent passes through. From the right side, the stent still doesn't pass through. So we have taken a 7 millimeter balloon, and we are going to dilate this now. This is 7 millimeter?
Yes.
Okay, go up. So this is where we are right now. Go up. 2, 3, 4, 5. That's it. 6. Deflate.
Yeah.
Okay, come this side. So we are here, now we are going to take two 10 millimeter into 10 millimeter epic stents and then go with the stents up. Hold.
It's not deflated.
Okay, get me another stent. So do you think, because we need to stent the external iliacs first because they are smaller diameter vessels and we can only put a 10 millimeter inside a 8 millimeter and not the other way through.
80. So we take 10 into...
10 into 10, both 10 into 10.
Yeah.
This is 10 into?
1080.
Okay.
Anyway, we have checked it.
No, then we
go
take 1080, two
1080,
1080.
another 1080.
Dr. Khanna,
Yes?
suppose if you try the
1080?
reverse strategy, that means you first put the stents into the aorta to the iliac extension, and then extend down below, like A followed by the B, whereas right now you are doing B followed by the A. Does it make any difference?
It actually does, because then we will have the 10 millimeter stents above would be ending into iliacs, and then you are putting a 8 millimeter stent which is hanging inside the 10 millimeter stent. So that is not a good strategy. It's going to probably lead to a lot of stent thrombosis, chances of stent thrombosis. So that's not a good strategy. I mean, as a standard strategy, it has to be the lower profile stent first, and then to be telescoped with a higher profile stent. So now this stent goes easily, go up,
Come down.
and
Yeah, that's location, sir.
what we are going to do is do a simultaneous kissing stenting here at the,
Yes. Just
it's okay,
shows.
shows the, so we are
Minus.
covering the stents properly.
Yeah, but what are the chances of foreshortening from the trailing end here?
Usually epic stents has a very little foreshortening. So this is not a stent like a wall stent where the foreshortening is a big issue. What is going to happen once I deploy this, what you will see is the stent is going to jump. So we have to be sure to pull it back, and that is why we have got two stents as a marker.
So they go up simultaneously or one after other?
They go up simultaneously, but I'll show you how we do it.
Shall I open left?
Just 1 second, no, move on. So you see this, now this stent is flared up, I'm going to stop here, so this will be like a marker for the other stent, and then I'm going to deploy the other stent.
We'll come little down, sir.
Yeah. And I would definitely first go up because this is going to jump, and then I'm going to pull it back. So once I have a double funnel like this, then my job is easy. So they are like, they are not going to saddle one over the other. So once I'm done like this, I'm going to wait for about 30 seconds because the nitinol would take some time to adjust to the aortic wall. And once it is fixed there, then I'm going to release the other part of the stent. So this is what I follow every time, and I could be mostly, I have never got into problems being precise putting in two self-expanding stents. So I have done the left side. Now I'm going to do the right side. This stent also must be fixed right now. Okay. So I'm done. So what now I'm going to do two kissing balloons by 8mm balloons on either side, and that should probably do the trick because I don't want to overdilate, or because these are self-expanding stents and there is a ulcerated plaque which I don't want to disturb much. My idea is to just open the aortoiliac stenosis and cover the ulcerated plaque in the aorta to prevent the trash.
Two 10mm balloons.
So all of you must have realized that Dr. Khanna deployed amongst the aortic stent, one stent was deployed only minimally, just a few millimeters, which allows him to pull down the stent in case if he is required to.
No, we want 1
Deployed
7
the
1 8
second
or 2
one,
8.
matching the
Whatever
first
we have,
deployed
but
stent.
fast.
And
get
then
the
continue
picture
the
ready.
deployment. So this is how you are going to get the
You have
upper
another
ends
60?
of the stent in one particular line.
Yeah, it's the same.
Okay, what is this?
No problem.
Take the other 8.
Yeah, both.
And the gradients which we are seeing, there is no gradient right now. We have already abolished the gradient. Get the other balloon on the other side. Okay. Sometimes, because of the calcified spicules, these balloons may get stuck. So you just have to pull down, rotate, and then push it up. These are 7 and 7 or 8 and 8?
Both are 8.
So we'll go with
860.
low pressure.
So what are the stent diameters you are used, 8 and 10?
No. Yeah, 80 millimeter in length and 10 millimeter in diameter. Okay.
Just dial it.
No. Just have to rotate. Okay. So this is very simple, when they get stuck, just pull it back, rotate, and then push. Normally they catch it on the calcified plaque, and it's very important whenever you are doing such patients, always do a CT, because that gives you the real picture inside rather than relying only on two-dimensional angios.
Okay.
Okay, we'll only go low pressure, okay?
Yeah.
4 or 6 or 6, something like that. No, you go with this.
Yeah.
Hold this.
These balloons usually have a long overhang. So do you still want to keep the markers there, or you want to come down?
6.
No, I think they're fine. We are just going low pressure, deflate. Because they have shoulders.
Yeah. Wait, leave it
Okay.
for some time.
Our purpose is not to expand it there. Our purpose is to expand it below. Okay. Go up, low pressure. Just low pressure, 4 and 4.
4.
Okay, that's fine. Deflate. Now we do at the bifurcation and at the overlap. Okay.
Yeah.
Just center the table. 4 and 4.
Stay at 4. Maintain.
4, stay at 4, 4 and 4.
Yeah.
Okay. Deflate.
Yeah.
Okay.
Yes.
Go. 4 and 4. Center. Remember, the optimal balloon pressures in peripheral balloons are normally 4 to 6. So unless they are high pressure, on this one, you go to 6, on the left one.
6.
Left one. You're on the left one?
No.
Okay, deflate. So never be going to coronary pressures because unless it's a non-compliant balloon. So now my next step is to take a pigtail up and do a final shot, and let's see what we have there. If we had an FFR, I would have also checked that renal on the left side and seen if there was a significant gradient, we would have probably stented that renal, especially in the view of history of hypertension, renal failure, early renal failure, and renal artery stenosis. But that's an optional thing, and if I had an FFR and I was convinced, I would have probably done that for the future protection of the renal functions. What is your view on this? Hello?
Yeah, we are listening to you, Doctor.
So what would be your take on the renals? Because the left renal has a stenosis, but only a borderline stenosis.
No, actually, we need to see the renal images again.
Okay. Can you play the first angio? Pigtail?
Fix the
Fix
renal.
the
Fix
renal.
it. Fix.
Okay.
Yes.
Usually it is a borderline.
Yeah, it is borderline, so that's why I said maybe an FFR may help, renal FFR, because there's a lot of literature now saying that if you have a renal artery stenosis which is borderline and you have a FFR less than 0.8, probably these patients may benefit in terms of preserving renal functions, not in terms of controlling hypertension.
Dr. Khanna, we have got 10 minutes more to go.
Yeah, we are almost done. Okay, you're going to Dr. Manjunath's lab or?
No, he has done BMV very well, excellently, good demonstration, and he has done with the case.
Okay, super. Let's go on the other side. Give me another balloon here, 7mm balloon on this side. Hold this.
We'll
Hold this.
take from the left
Other
side.
side, yeah.
Yeah.
Your injector is ready?
Mostly it goes from left.
Holding?
Yeah.
Show me. Move the table. Okay, so. Ah. That's interesting.
Is it the same calcification?
There is a thick calcification where it catches, so I will again try to rotate it or maybe take a different wire or dilate it once more. So this is not a stenosis, but this is because the stents are well expanded, but it is some spur of calcium which is...
Suppose if you go with a right coronary catheter and change the wire,
Yeah, I will do that.
upgrade the wire to little stiffer one, will it
Yeah,
make it?
definitely, that would be my strategy. I will do that right now. Give me an RCA and give me an
Give us
Emplatz
the-
wire.
Yeah.
Or simpler, maybe try going from the other groin. It might just go.
Yeah, I would do that as well in the meantime. Because I had a little problem when I went with the pigtail on the right side, so I changed it to the left side. But I think it's better we change it to an Emplatz wire.
Emplatz are extra stiff.
Because Magic Torque is a floppy wire with a floppy distal 5 to 10 centimeter. It's- Oh.
Yeah.
Okay. Go up. Give me an Emplatz wire. Hold this. And I'll need the
Yeah,
balloons
give us the
again.
pigtail system.
Show up. Up, up.
The pigtail.
And every time you're using an Emplatz wire, especially in patients who have coronary artery disease and grafts, it's better to go without wire with a pigtail to the ascending aorta and then put his introduce the stiff Emplatz wire. Otherwise, you can have an arch atheroma and an embolism into the cranial circulation. Hold this.
Yeah.
Good. You ready with the pressure injection? Can we do a DSA?
Yeah. DSA, but we can't see both ends. You can see upper
Okay.
end.
Fine.
Come down. Come down.
Here we.
No, not yet gone. Yeah, now we are. Yes, yes.
So this wire looks better, so I can pass in easily.
Yeah.
Okay. Pigtail. And
Would you like to do the DSA picture or
Pressure
conventional
inject.
coronary?
if I have to do a DSA, it has to be then in 2 stages because we can't move the table. So I was thinking of a conventional coronary. Pull back. Okay.
Yes. Yeah, I think that's good. That's fair enough.
Okay.
Okay. And
Go on a coronary frame. And how much of dye you are giving?
25, 40.
20 is enough.
Yeah.
15, 14 at 1100 or 9, 10, 1000 psi.
Yeah. Sir. Flush. Flush.
Okay,
Yeah,
let's
fine,
be fast.
fine. Okay, done,
Okay, go.
done.
Fine, just
Yeah,
move the table.
done. Move and show.
Okay, pan the table. Okay, fine.
Yeah.
Go.
Yes.
No, no, you don't have
No,
to
no,
fix. You have to move the
You
table.
have to move. It's
This
not
is non-DSA.
Non-DSA. Just change first.
So,
Some-
Dr. Khanna, I mean, what are we trying to suggest in a severely atherosclerosed vessel like this?
Okay.
You are very gentle on your inflation pressures, isn't it?
Yes, because these are compliant balloons, and if we really have to dilate, now I'll take Mustang balloons and then dilate with high pressure with those balloons. Because I don't want to displace the plug and I don't want any trash. Okay. Go down. So this looks good. You can't see the ulcerated plug now because it's well covered. The only thing I need to work on probably is to go down and work on the iliacs with a little, high, non-compliant high-pressure balloons. And the renal is something which I'm going to probably, I'm not too sure. If we had a FFR, we would have done it. Do you want a DSA on this? Or you think it's okay? Because I don't want to give a lot of contrast.
I believe there is always a renal dysfunction in this.
Yeah, so I think it's fine. What you see is the aortoiliac lesion is opened up well. All the external iliac lesions are fine. There is a decompression. The dye is not sticking into the ulcer. It's very well covered. And also, what you are seeing is the collateralization has decreased in a major way. So that again signifies that the antegrade flow is good.
That will connect to sheath.
Give
So
me a
good
press.
result, Dr. Khanna. I think we have about...
And if you see on the monitor, if somebody can show me this,
Yeah,
Monitor.
No gradients.
there is zero gradient.
It's an
You've got
excellent
a-
job.
It's coming there.
Oh, it's coming up there, yeah, so,
I think we are going to delink in another 2 or 3 minutes.
Okay.
All right, Padmanabhan? We are going to delink now?
Yeah, we'll be delinking in another 2-3 minutes.
Yeah.
give me another balloon for the right side.
Anything?
Yeah, 7 millimeter.
I think both Dr. Khanna and Dr. Manjunath moved at 2020 speed. So we finished before time.
Yeah, because we knew you were moderating, so we had to be fast.
All right, any questions? Otherwise, we close this session. Thank you, Dr. Khanna and your team. Thank you for all the panelists who are on the stage.